both these women have contributed greatly to the DOH's contribution in the district, and it's made a huge difference. Amanda also works at GW as part of the public health school, and we do a lot of work together. And it's been a real benefit for me, and a real benefit, I think, for the city, to have the places that do clinical care, because whitman-walker still makes up about 30–40% of the HIV care in the city, to be able to work closely with the Department of Health, and also to be able to work closely with the universities that help give us a lot of technical expertise. And Amanda's helped put a smiling, normal human face on a situation that up to now has not been either competent or human. So with that in mind, give her a warm welcome.
Well, thank you. That was more than a kind introduction. But I do want to, before I start, acknowledge that I do have colleagues here from the health department, from the GW partnership, and also with the health department, and also from GW, who have definitely helped to contribute to much of the data that I'm going to present to you today. So. And I think that Dr. Elion has laid a great foundation here for, I think, a lot of the issues around PrEP you're going to see resonate in some of the data I show you. And so it'll be interesting to get your perspectives on this. This is our first presentation of all of this data. So this is coming from multiple different studies. So as I think Dr. Elion laid out, now I see why you took this off. Okay. We do have a lot of data on PrEP and its efficacy, and it's showing that this is actually a potential tool for preventing HIV transmission. As Dr. Elion also mentioned, the CDC has issued interim guidance for providers as to how to prescribe PrEP, initially to men who had sex with men, and then about a month ago they came out with recommendations also for how to prescribe PrEP among high-risk heterosexuals. And so given that there's a lot of momentum with getting PrEP implementation up and running in various jurisdictions and various places in the United States and also throughout the world, again, it raises these issues around implementation. So all of these studies to date have really been in clinical trial settings. So people were constantly reminded that they needed to come for a visit, that they were really being followed very closely. And we all know that a study setting is completely different than a real life setting. The other issues have been mostly around adherence. So again, we sought to try to understand issues around adherence and taking PrEP as a daily oral medication. And then issues around cost. So how much would people be willing to pay? How much is insurance going to cover this? And then lastly, some of the issues around risk disinhibition, which we talked about, which is basically the idea that people will say, well, I'm taking this medication so I'm protected, so I can go out and have many more partners and be more promiscuous and not use condoms. And so a lot of conversation when those first IPREX results came out, there was a lot of conversation, again, as Dr. Elion mentioned, the three of us actually work very closely together. And so there was a lot of discussion among providers and among health department employees as well as to what's going to happen with PrEP. And is there going to be demand for PrEP in DC? And so instead of operating in kind of a silo and kind of guessing what the population was going to want and how providers were going to address this potential need, we decided to try to get some actual data to support what would happen in DC. So how many of you all are working in DC? Just a show of hands. Okay, so most people. Okay. So you all are probably pretty familiar with some of the data regarding HIV and AIDS in DC. Basically, the last annual report showed us that between 2006 and 2010, we had approximately 3% of the DC residents were living with HIV or AIDS. That's over 14,000 people who are living with HIV. And during that 5-year time period, we also had over 5,000 new cases per year. And when you look at new diagnoses by risk, you can see in this pie chart here that the vast majority were men who had sex with men, but we also had about 31% of new cases that were attributable to heterosexual infection. And so you can see where the role of PrEP would be, could have a potential impact on reducing new infections in DC in particular. The health department has really been working very closely. They've gotten a lot of funding given the high prevalence in DC, and they've been working very closely with CDC. And CDC traditionally has really focused on developing high-impact prevention programs. So I'm sure you all are familiar with EBIs and DEBIs, these evidence-based interventions for HIV prevention. The city has also started a condom distribution program that's citywide, so people can get free condoms. They can get as many as they want. Individuals can come to the health department and get condoms. In 2006, the city also started doing routine HIV testing expansion. So as Dr. Elian mentioned, the whole concept of HIV opt-out testing was implemented broadly throughout the city. And the city also has provided some funding for post-exposure prophylaxis, although it's been a very limited distribution of that funds. And there's actually been, anecdotally, a lot of limited use of post-exposure prophylaxis when we talk to providers. And then lastly, I put in there PrEP, because again, our question was, is this going to be something that would be useful in DC and would be of interest to both high-risk individuals and providers? The third thing I wanted to mention was that after the IPREX results came out, again, there was the momentum nationally and locally, but today there are this many studies that are either starting to enroll people in PrEP or are in the planning phases. So there are 2 studies that are going to be conducted by my colleagues at GW. HPTN is the HIV Prevention Trials Network. So they are starting a phase 2 study to look at the use of Maraviroc among MSM. So they'll be comparing people who get Maraviroc to those who get Truvada to those who get a placebo. There's also going to be a study looking at Truvada among young Black MSM. The ATN is the Adolescence Trials Network, so this study is going to focus on providing Truvada among youth and young people who are men who have sex with men. And then the health department is actually in the planning phases of putting together a Medicaid demonstration project. And so that project ideally would be available obviously to anyone who gets Medicaid, but it would be providing Truvada to men who have sex with men as well as high-risk heterosexuals. So that will be a citywide project, probably, I think, enrolling about 200 to 300 people. And then as Dr. Elian's clinic is going to be starting also a PrEP demonstration project. And I believe, he can correct me if I'm wrong, but San Francisco will also be participating in this, and I believe Miami. And so that will focus also on providing Truvada. So given all of this context, as I mentioned, we had 2 objectives. One was to talk to providers to figure out how much current use of PrEP was actually going on, and also to get their perspectives and their opinions about PrEP, and about which of their patients they thought would be most appropriate to receive PrEP. But we also wanted to know if people in Washington were interested in using it as well. And so we talked to potential PrEP users. We did 2 things. We conducted a survey among these patients, and we wanted to really figure out how much knowledge was there around PrEP, what were people's attitudes about it, and were they even willing to consider this as a prevention method. And then, because surveys are sometimes limited, we also did focus groups as well. And so we had 3 focus groups, and basically I'm going to show you the results of the provider data and then the potential PrEP user data. So for the providers, we conducted an online survey of infectious disease physicians and HIV providers. We also conducted in-depth interviews with 9 local providers. With the potential users, we conducted the survey at 3 clinics. We really tried to get a broad population in this clinic. So we worked with Whitman-Walker. They have a clinic, and I think I saw Rodney Perkins, who helped with this data. He and several of his colleagues helped us recruit people from the Gay Men's Health and Wellness Clinic. We also worked very closely with the health department. They have a free STD clinic in Southeast, and so we recruited individuals from there. And then we also worked with Children's Hospital, Children's National Medical Center, and we worked with them in their adolescent clinic because we realized that this study was coming up among adolescents, and the data to date actually have not included adolescents, even though they are going forward and providing this medication. So we thought that it would be important to include them as well. And then, as I mentioned, we conducted 3 focus groups. The groups were basically one focusing on what we considered high-risk heterosexuals, men who had sex with men, and then adolescents, to try to couple that information with information we were getting from the surveys. So the results of the provider data. First off, we sent an online survey to about 125 providers. We followed that up with a paper survey because we were trying to get a good response rate, and it's hard to get people to actually fill out surveys these days. We did give them a $20 gift card for completing the survey, and we received our responses between March and August of this year. So we received 58 completed surveys out of that 123. And of those 58 providers, they were mostly over the age of 50, mostly white men. Infectious disease physicians definitely completed the survey more than other providers did. And as you can see from their practice characteristics, most have been in practice for several decades. We tried to get a sense of the volume of the patients that they cared for in general, and then also the volume of HIV patients and clients that they cared for. And so you can see that almost 85% had seen their clinic had taken care of an HIV-infected person in the last 3 months. And we tried to get a sense for the provider, him or herself, how many clients did they care for. And again, you can see that about 76% were caring for more than 20 patients a month. So probably pretty well versed in treating HIV-infected patients. We tried to measure their perspectives on what they felt were the most effective methods of decreasing HIV acquisition, and we gave them quite a few options. As you can see, they thought that condom use was actually the best way to prevent HIV infection, and that was about 62% of the providers. And we also asked them, obviously, about oral PrEP, and only about 25% of them thought that that was the most effective way. And I should back up and let you know that these were questions that were asked on a scale of 1 to 5, so 5 being the most effective method, and this is really just representing those people who thought it was absolutely the most effective method. We also tried to understand whether or not they thought it would be feasible to provide PrEP in their particular practice setting. And so again, we asked them if they agreed, strongly agreed, if they were kind of neutral about it, disagreed, or strongly disagreed. And again, you see that here, the longest bar over there is the agreed, which was about 40% of people, and 20% of people strongly agreed. So again, about 60% of the providers thought it was feasible to actually provide PrEP within their practice. We also asked them if they thought they would have the time to do it. So again, as Dr. Elion explained, this is a pretty intensive HIV prevention approach. The patients have to come regularly for the HIV testing. You have to test them at baseline. You have to check their renal function. You have to test them for STDs, et cetera. And so we wanted to understand also if they felt like they had the time to be able to do all of that. And again, you see that most people did agree or strongly agreed, and that was again about 70% of the providers. We also wanted to try to determine who would you give PrEP to. So we asked the providers, who are you most likely to prescribe it to? Interestingly, most people thought that they would provide it to someone whose partner was HIV infected. And I just want to point that out because when we talked to them, those 9 providers in depth, we got a little bit of a mixed result from there. So even though the survey people said most people who had a partner who was infected, the focus group and in-depth interviews were a little bit different. We also were interested in figuring out if they would be interested in providing PrEP to people who, oh, sorry, yes.
Did you give them the acronym for PrEP?
Yes. Yes. So they understood what PrEP was. We gave them basically a one-sentence definition of what it was. So when they were answering these questions, they knew what we were asking about. And I'm not presenting the other part of the survey, which was actually also focusing on PEP, on post-exposure prophylaxis, just because that's been around so much longer. We were trying to get a sense also if that was a method that people were using, or the providers were using as well for HIV prevention. But yes, they were aware of what we meant by PrEP. So again, we asked them who they were most likely to prescribe it to. Again, a partner who is HIV infected. But the first 2 bullets there are patients who had a history of not adhering to prescriptions. Because again, adherence is such a key element of being a good PrEP user that we wanted to get a sense of, you know, if providers think, well, this patient never does what I say they're going to do, even though they may be at high risk for HIV, I'm still not going to necessarily talk to them about PrEP. Similarly, the whole visit cycle, so the baseline visit, the 1-month visit, the 3 months, 6 months, etc. We wanted to get a sense of, well, if they thought that these people weren't really good about returning for their visits as scheduled, you know, would that preclude them from providing it? And so you can see here that it does seem to impact the patients that providers were most likely to prescribe it to. We also tried to get a sense of what their primary concerns were with regard to PrEP. And so you can see at the bottom that the most reported concern was this development to antiretrovirals. So again, despite the fact that in the IPREC study, there really was not this huge concern, well, not a huge concern, but that we didn't see anyone who had viral resistance. About 30% of our local providers actually are concerned about that over a longer period of time. And then 20% again were concerned about the fact that their patients would start to have more risky behaviors. Okay, so that whole concept of behavioral disinhibition. And then the third most reported concern was the cost. So again, who's going to pay for this? How is insurance going to cover it, et cetera? All right. These next couple of slides are I know they're really text heavy, but they highlight some of the data from the interviews, and I just want to point out some of those major findings and themes. So again, we interviewed about 9 providers in the area, and first of all, I'd say there were mixed levels of acceptability of PrEP use among the providers. So one provider said, you know, I would talk to patients about it, but really that provider, him or herself, had mixed feelings about it. And that provider said, you know, I think our healthcare dollars would be better spent treating people who are HIV infected. And we heard that, you know, from a couple of people. Another provider mentioned that he couldn't think of any other infectious disease that we're using to prevent with a daily medication. So we do pre-exposure prophylaxis for things like malaria, but that's usually for a relatively short amount of time. But for someone to be potentially on a lifetime of PrEP was a new concept to some of the providers. And then the third bullet was It's kind of like this argument where you don't want your kids to have sex, but then do you buy them condoms just in case they have sex? But then you're telling them it's okay to have sex because I'm giving you a condom. So it's this catch-22 of, you know, well, if you're not going to behave properly, if you're going to have high-risk behaviors, maybe I should give it to you, but then I don't really want to condone it. And then the last person, one of the last quotes that I wanted to highlight was really about the efficacy of using PrEP. And so the IPREP's initial study results showed this 44% reduction in efficacy. And so this provider said, but 40%, and then we of course said, well, it's 44%. And he said, okay, 44%, I still think that's too low. You know, I mean, post-exposure I think is 99% right, so 1 in 1,000. So again, that comparison to PEP versus PrEP and the different levels of efficacy. In general, when we talked to those providers, they did have experience prescribing post-exposure prophylaxis, but there really had not been demand at all for PrEP among those providers. Again, this is a small number of people, but they do take care of many HIV-infected people, and so you would think that they would be a little bit more attuned to this. But one provider said it doesn't seem that in this area there's really a clamoring desire for patients or for practitioners to use PrEP. So, you know, basically he went on to say that he thinks that in DC you would think that there would be a lot of interest because of our high prevalence rates, but to date they haven't really seen that much. That said, other providers did acknowledge that even though there had been a very little demand at this point, that they really did need education and a good approach to be able to deal with patients who were interested in PrEP. And so just for the sake of time, I'm not going to read that whole quote. Similar to the survey results, we definitely had providers who raised concerns about the cost, again about adherence, and interestingly about which patients they thought should receive it. So one of the providers said, my first question would be, who's going to pay for it? You know, it's a great concept potentially, but if there's no money behind it, how can we really implement this? And then the second one, he said, was adherence, because that's abysmal too. The second bullet is just to highlight that the issues around, again, that potential for viral resistance. So the provider said, let's not forget, I mean, there are risks for drugs such as Truvada, especially anything with tenofovir in it. So, you know, this is not necessarily a benign drug. There are potentially minor side effects. But if someone were to seroconvert, then you have to consider the risks of resistance. The other bullet was, I think that unless you're in a situation where the person cannot control their sex drive, how do you know which one those people are? It's difficult to say. You really can't determine necessarily who it is that would be, again, the best candidate there. And so if you don't engage in high-risk activities, there shouldn't be a need for you to be taking this. There shouldn't be a need for anyone to do this, but then again, it's not a perfect world. And so again, dealing with the reality of patients, and they may have good intentions, they may want to reduce their risk behaviors, but it doesn't necessarily mean that when it gets down to it and they're in that situation, that they're going to use a condom 100% of the time, for example. When we talked to the providers, there was, again, going back to that survey data, you remember that most of them thought that they would most likely prescribe it to people who were in serodiscordant partnerships. But when we talked to them, there was actually little interest in using PrEP for that purpose. There was definitely a strong preference for treating people who were HIV infected and getting them to be virally suppressed versus treating an HIV uninfected person. So I thought that that was a very interesting opinion and approach. Okay, so that's the provider perspective. I don't know if there are any questions. Yes, I see a hand, but yeah.
More towards nursing in terms of treating of the disease rather than being preventative. So if you're looking at it from the perspective of treating the HIV positive person versus let's use PrEP to treat not just, use PrEP to treat partner and use the other medication to treat the positive partner as well. So you have to consider or put into conscious thinking about not just the positive person, but also the partner. Because as of this moment in time, we're not really interested in the negative partner. We're interested in the positive partner. So I guess that's where the focus is. So this is technically a new perspective, a new way of thinking, not just to focus on the positive person, but also to bring in the negative partner.
So I'm going to try to paraphrase what you said. I didn't hear the first part about nursing, the context in there, but...
Holistic kind of preventative methods of helping people.
So I think your comment was that this is kind of a shift in thinking, where traditionally we've really been focused on the person who's infected, and now we have to make this shift and think about how can we address people who are uninfected in this context. And I agree with you, and I think that, you know, again, this was a biased sample, for lack of a better term. We did not talk to primary care providers who do not necessarily treat HIV infected people. We're really talking to people who are known in the city to care for a large volume of HIV infected people. And so that makes sense that their mindset would be there, right? But I think it would be interesting to potentially survey and talk to other providers who are not necessarily infectious disease or HIV providers to get their sense of, you know, do their clients even talk to, or do they even talk to their clients about their sexual risk behaviors? And I'll get to some of that when I talk about the potential user focus groups. But, you know, are you having this conversation as a journalist? Are you having the conversations about risky behaviors in HIV with everyone in your patient population? I think there was another hand. Yeah.
What providers are participating in the test Make the Care project?
So for TLC Plus, the question was what kinds of providers are participating in TLC Plus. So TLC Plus is, we could spend an hour talking about just that study, but DC is one of several cities that are participating in it. And so there are, and Sarah, you can correct me if I'm wrong, I think there are about 30 providers? 20 providers that are participating in it. They range from hospitals to community-based organizations. There are many different components of the study. So the first component is actually ramping up and scaling up routine testing. The second component is this linkage to care. The third component is getting people to remain in care. And the fourth component is getting them to a point where their viral load is less than 400 copies per milliliter. So at each of those different stages, some of the sites are providing incentives and some sites are just doing the standard of care. And so we will see what the impact is potentially of those financial incentives. It's in Washington where they're doing the financial incentives, New York City, in the Bronx. And then there are a couple of control communities as well. So I think those are Miami, Chicago. You all are more involved in it than I am.
Philadelphia, Atlanta, Miami,
and maybe Detroit. There are four control communities and 2 intervention communities.
But the other 4 communities are really just kind of observing people to see if they do get tested, linked to care, engaged in care, and become virally suppressed. And you had a question.
Yeah. Going back to provider perspectives on most effective measures to decrease HIV acquisition, the graph. Surprisingly, I found that according to the survey, condom use, as you said, ranked highest compared to abstinence. I mean, can you explain a little bit?
I cannot explain. Yeah.
I can explain that. The idea is that if
Sorry, let me repeat the question. I guess the gentleman was wondering why condom use was seen as a more effective method of HIV prevention than abstinence. Remember also that the people that we surveyed, so they are infectious disease and HIV certified providers in DC. So they are seeing people who are not abstinent. I'm sure that probably colored some of the results that we got, but did you have?
This is not an evidence-based comment, so this is my personal opinion. But it's my experience with patients that patients who claim abstinence aren't necessarily abstinent. So the question about what is ultimately effective is if a person pledges to abstinence, whether they get that way, and whether a person uses condoms, then you judge the relative effectiveness of the two modalities. And the people in this group said that they thought condoms are more effective. In other words, people who said they were going to be abstinent probably weren't abstinent, because if they were truly abstinent, then there was no exposure.
I also think you have to remember who's answering the questions. So if this is an exam, and someone said, and the question is which one is the most effective, then you would say abstinence is 100%, because that's the exam type question, right? That's the evidence one. But if we're talking about, as Dr. Elian just said, the reality, if you ask me that question, I would probably have the same answer. Yes.
I think the question that comes from my colleague suggests that if a human being is infected, then sex is not a normal thing. I think it's a normal thing, and to expect human beings to abstain from something that's natural and normal doesn't really, it puts pressure on people, and all they would do is tell you lies.
All right, we're going to move on. So that's the provider perspective that we have on PrEP for DC. And now I'm going to share with you some of the data that we found from potential users of PrEP. So again, this was a survey that was conducted at 3 different sites. In order to be eligible, you had to be 13 years of age or older. You had to be self-reported HIV negative. You had to have had sex in the last 6 months. And you had to be able to complete the survey in English, and because it was a study, they had to provide us with informed consent. So we screened a total of 373 people, and basically to get to the bottom line, we ended up getting completed surveys on 293 people, and I've just given you the breakdown that the majority of those came from the DC Department of Health STD clinic. So again, these are people who are presenting to the STD clinic either because they're getting HIV testing, because they're symptomatic, maybe they've been referred because a partner was positive, so probably a pretty high-risk group for HIV. And then, as I mentioned, we had 75 people from Whitman-Walker, from the Gay Men's Health and Wellness Clinic, and 43 adolescents from Children's Hospital who were there for a routine visit and screened in the absence of their parents to determine if they were sexually active.
Did you provide an incentive for this?
Yes, so we did provide an incentive for this. The incentive was $20 for completing the survey. It was a self-administered survey. We used iPads so that we were not asking them, because we asked them pretty personal questions. And so we, to reduce some of that bias, we had them administer the survey themselves. It took about 15 to 20 minutes to complete it. So just a quick breakdown of the characteristics of the people who completed the survey. The median age was 26. You can see we had a range of people ages 14 to 66. More than half were male. The majority were non-Hispanic, Black, and DC residents. It was actually a pretty educated population, so about 52% had completed some college, and about half of them had an annual income of over $20,000. About a third of our sample was on Medicaid. And then we also asked them some information about their relationships, who they were having sex with, and their sexual behaviors. So about 60% of people were in committed relationships. And then as far as sexual behavior goes, 23% were homosexual or bisexual, again self-reported, 33% were heterosexual men, and about 39% were either heterosexual women or bisexual women. We asked them about their HIV risk factors. We asked them about main partners and casual partners. The median number of main partners was 1, although you see the range was 0 to 33. A casual partner, the median was 2 and the range was about 0 to 35 partners. So we're not sure if, maybe somebody entered 35 instead of 3, but it could be that, maybe someone has multiple partners. About half of people said they use condoms most of the time or always, and about 53% said that they knew their partner's HIV status most of the time or always, and about 66% actually thought that they were at no or low risk for HIV infection, which I think is very interesting. Other studies have also looked at self-reported HIV risk and PrEP use and found that, again, just if you look overall, people really don't see themselves at risk. Again, because of the context in which PrEP is prescribed and monitored, we tried to get a sense of people's general health-seeking behaviors, and also their HIV testing behaviors, because you do have to get tested regularly. So 60% of people said that they did have a regular healthcare provider. About a third of them were getting their care at a community health center. And about 75% of them had had at least one healthcare visit in the last year, but 1 to 4. The vast majority of people had had a previous HIV test. Some of that, again, is because of the eligibility. So in order to report that you were HIV negative, we assume that you had to have had a test in the past. But we tried to ascertain the frequency of testing. So over 70% had had a last test within the last 6 months, the last HIV test. And the median number of HIV tests in the last year was 2. So you would assume people are possibly getting tested every 6 months. Clearly, the person who had 20 tests in the last 12 months was, well, they may have been getting tested, or they may have had some high-risk behaviors. Oftentimes, anecdotally, we do have people who will go to the STD clinic and get tested pretty frequently. So, we also tried to get a sense of medication adherence behaviors. So again, the idea being that that PrEP, the way it is currently prescribed, is a daily oral medication. And so of the 293 people, 97 of them reported that they were currently taking a medication that was prescribed by their healthcare provider. And we tried to get a sense of, well, how good are you doing? How well are you doing in taking that medication? So 65% said that they sometimes forget to take their medication. And I bet if we had a show of hands here, it probably would be about 65% of us, if not more, that, oops, I forgot to take that pill today. Or, people who they're prescribed an antibiotic for a 10-day course and only finish 5 days because they're feeling better now. We also tried to get a sense of how often they were missing their doses. So over the last 2 weeks, we asked them to recall how many days they had missed that medication. Again, the median was 2, but the range was, I didn't miss it at all, to I missed it pretty much every day, 14 out of 14 days. There's concern about the side effects of PrEP again, and so we tried to get a sense of, well, have you ever just stopped a medication because you didn't like the side effects? But not listed on here, or you were feeling worse, but 30% of people said that they had done that. And then we tried to get a sense of, well, when you did that, or if you've done that, did you actually tell your healthcare provider? And so again, about another third said, no, I didn't tell him or her, I just pretty much stopped it. And so I think this will give us a good clue as to what we could potentially see when we do have more broad implementation of PrEP. We also tried to assess people's knowledge. We figured again that we'd start off with post-exposure prophylaxis just because it's been around for longer. So we did have a fairly good number of people who had heard of it. 70% of people had heard of PEP. Only 5 people actually reported using PEP, which is probably an underestimate when you talk to providers and they talk about people who they provide PEP to often. About 10 or 11% had actually heard of PrEP. After, again, we kind of gave them a general idea of what we meant by PrEP. At that point, only 1 person had used PrEP, which is not surprising, because again, this is still pretty early in the implementation phases. And then similar to what we asked the providers, we also asked patients, you know, given that you have all of these different possibilities, what do you think is the best method for HIV prevention, or your preferred method for HIV prevention? So essentially they ranked, you know, what they thought was the most effective, and condom use, again, came out on top. We did ask them hypothetically about a vaccine if it was available, but 20% of people were interested in that.
Do you have any information on the 1 person who'd used PrEP?
I have not looked at that 1 person yet. Yeah, I'm not sure who it was.
Or the site?
The side effects of PrEP. So I think you talked about it a little bit, but you might have nausea. We also monitor people for renal toxicities as well.
Kidney.
Oh, sorry, kidney. Sorry.
Just in case.
We also tried to assess the willingness to use PrEP. So again, we told, when we started the survey actually, when we built the survey, the results were, had basically just come out, okay? So people were getting some kind of hypothetical questions at that point. So would they take PrEP if it was proven safe and effective? So 77.5% of people actually agreed that they would, somewhat or strongly agreed that they would take it. Then we tried to get a sense of, well, when would you take it? Would you prefer to take it before sex or after sex? And 26% felt like it would probably be easier for them to take it after they had had sex. Now again, that's not the way it's prescribed now, but there's definitely interest in people being able to take it intermittently or either just before or after a high-risk sexual encounter. 86% of people were interested in learning more about it. When we asked them specifically, would you be able to take it as a daily oral medication, about 61% thought that they could do that. We also tried to get a sense of how much people would be willing to pay for it. And so the median amount was about $20 a month. We said, well, what if, knowing that we knew that the health department demonstration project was coming up, and we knew that some of these clinical trials were also coming up. So we also asked them, well, if your insurance covered it, or if it was free, would you be more likely to take it? And again, about 57% of people said, oh yeah, I'd be very likely to take it if it were free, or I knew that my insurance would pay for it. And then we asked them about the interest in participating in a clinical trial, and only about 1/3 of people expressed that interest. We just did a kind of quick and dirty analysis for you all to try to get a sense of the willingness and whether or not that varied by risk group. So whether or not men who had sex with men would be more willing to take it than than, for example, heterosexual women. We also wanted to get a sense of, was there a different distribution by age group or by gender? And so basically the long and short of all those numbers is we didn't see any difference. So everyone, based on gender, age, and sexual behavior, was equally as likely to be willing to take it. All right, so again, just like we did with the providers, we coupled this information with our focus groups, because sometimes you can get much more insight into what's driving people's reactions and feelings about a particular issue by sitting down and talking to them. So eligibility, again, people had to be HIV uninfected. We had 3 groups, again, that focused on high-risk heterosexuals, MSM, and adolescents. At this point, we used adolescents who were over the age of 16, or 16 years of age and older. And we used a standard focus group guide for the 3 different groups. So for the adolescents, we were able to get a group of 6 people together. Generally, they had pretty high levels of knowledge about HIV, particularly in DC and the high prevalence rates here. But they definitely had concerns about PrEP use leading to increased STIs and also unplanned pregnancies. So one of them said, I think that's where like the whole medication thing, going to get some people messed up because you feel like you're Superman. So you're basically, you feel uninhibited, and we know that adolescents often feel like they are invincible. And so these adolescents were actually very attuned to that and concerned that people would just kind of start acting invincible. They also thought that PrEP would actually promote cheating and would condone promiscuity. And so they said, I think we were talking about this before, some of the issues around, if you had the pills on your nightstand, for example, and they were talking about, if I were with my partner, I'd be suspicious because I'd be like, why do you have these? I thought we were supposed to be in a committed relationship, so why do you have this HIV pill available to you or on your bedside? The adolescents definitely had a preference towards using condoms over having to take a daily medication for PrEP, but they were also interested in looking at the possibility of alternative strategies and in terms of dosing PrEP. So, one of them said, I think right before you have sex is better because you never know when you're going to get a quickie in. So not necessarily wanting to take it every day, but if I could take it before, I forget the exact words that they use, but before they got with their girl or boy, that they thought that would be better. And then we asked them, well, who do you think, because they were clear that they were not interested in really taking PrEP. So we thought, well, who do you think should take PrEP? And they thought it was interesting. They thought athletes, rappers, and groupies were the people where we should target our PrEP.
And these are people sitting in the STD clinic, right?
Well, no. So these were adolescents that we recruited from one of the community-based organizations in DC. But the rationale there was that these people have a lot of sex. Groupies want to be. I think they put it as the people who want to be popular. They're going to be more promiscuous, and therefore they should be the people who take PrEP. When we held our focus group with men who had sex with men, we had 13 men participate. We had really had a great turnout there. Again, they were very knowledgeable about HIV in general and about the high rates in DC. One person said, I think it being HIV touches all lives, no matter how much money you have, no matter what area you live in, or what kind of access to healthcare you have. Everybody is impacted by HIV and other STDs. We thought that was a very telling quote. They had mixed feelings about healthcare providers in general and their intentions around prescribing medications and the costs around medications. So there was a whole debate about whether or not physicians are in it because they're ethically and morally really invested in treating people, or whether it's just the bottom line and they want to try to make as much money as possible. And so that's what these 2 quotes show you, the 2 different perspectives there. In the same vein, when we were talking about, well, would you disclose to your healthcare provider, your sexual orientation or your sexual behaviors, they really were kind of hesitant about talking to healthcare providers if they didn't already have an established relationship with that person. So one person said, I've heard that some people that are more comfortable talking to somebody like an HIV counselor when they get tested about risky behavior that they participated in versus their doctor. It might have something to do with what you're saying in terms of the perception of the doctor's comfort level with sexuality. And so I think this is, again, a really important point, because if you're not comfortable talking to your healthcare provider about your sexuality, whether it's your primary care doctor or your infectious disease doctor, how is he or she going to even know that you're engaging in these risky behaviors and to even start talking to you about not only PrEP, but HIV prevention in general? Many people had heard of PrEP in this MSM focus group, so they'd heard about it through the news, the internet, their friends. They just had general information. There was one person who was pretty astute. He said, I heard there's a pill that you can take. It's the same pill that some nurses and doctors take when they get stuck with needles or something like that, which, of course, the person is referring to PrEP here. I heard that it's the same medication that they use for that to help with prevention of HIV. I'm not sure if it's correct, because I mean, you know, I never had to use it. So of course the person then says, well, I just heard about it, but it wouldn't necessarily pertain to me. Similar to the adolescents, there were concerns again about condom use or the lack thereof, the efficacy of PrEP, promiscuity, STIs, etc., the costs of taking PrEP. So this was an interesting back and forth. So the first person said, if I'm wearing a condom, I'm not going to need to take this pill. If I'm going to take this pill, I'm not going to need to wear a condom. And that's what people's logic will be. But then somebody else said, yeah, but maybe it'll actually also stop the spread of HIV, because this person kind of went on to say that he didn't really think that PrEP was the best method. And then the third person said, yeah, okay, it might stop HIV, but you can still get syphilis, you can still get herpes, you can still get everything else that a condom would prevent. And then the fourth person said, yeah, then it's gonna say, okay, so you're using your condom, so you already have this level of percentage of protection, and now we're slapping on another 40 to 60%. So meaning that if you do it in combination, which is ideally what you would want, that you're raising your level of efficacy and protection from HIV. When we talked to them about whether or not they'd be willing to take it, again, varied levels of interest. So one person said, if you're a high-risk person that has sex like every time and you're living in a community that has a high HIV rate, why not take it? Which would essentially be the DC situation. And someone said, but I mean, it's just like, it can be compared to the exact same way that the birth control was, and how people will forget to take it one day and end up with getting AIDS or getting, like, in women's cases, pregnant. And I've heard this analogy quite a bit, actually, not only from these focus groups, but also in talking to other scientists and researchers around PrEP. And again, these issues around adherence and whether or not people are really committed to taking a daily oral medication for prevention purposes. So I would not be surprised if we keep hearing about this analogy to the birth control pill. And then the last person said, well, it's still best to use a condom. It's still best to get tested every 3 to 6 months. It's still best to do all of these other things that you were doing before. This is just a level of security. It's a level of protection. And I thought that that was a great quote. The third group we talked to were heterosexuals. So we had about 10 people in that group. Again, they were recruited from a community-based organization here in DC. They were very knowledgeable about the HIV epidemic. The concept of PrEP was actually very new to most of these participants. They thought there would be a lot of interest. So the quotes were, I had to pare it down. They were very interesting. So one said, you'd have like a line, like you're selling dope. So they thought there was going to be, you know, people banging down the doors. I will say that they had this concept, like I think that Dr. Elion referred to earlier. It's not like condoms that are in the bowl and you just reach in and grab them. There were some of the participants in the heterosexual group who thought that it should be like in the machine where you put your quarter in. You're at the club. This is exactly what the person, you're at the club, you see somebody that you want to go home with, you say, excuse me, you go put your money in the machine and get your Truvada out, and then take the Truvada and then you're protected. And so it was really interesting that the level of knowledge and understanding of PrEP and how it should be used was really pretty minimal in this particular group. There are, again, concerns about decreased condom use and infections with other sexually transmitted diseases. So one person said, you know, that's the abusing part that she was talking about, like people who are going to start taking it and start abusing it, like thinking I don't have to strap up anymore. I don't have to put no condom on by taking this pill, you know. Basically, if I take the pill, I'm good to go. And then another person said, but you know it's going to get, the biggest misconception is going to be that it's okay, like you said I can take these pills, I can go and have sex with anybody I want without a condom. But there's still a whole lot of other STDs that are out there. So again, this recognition that if you're not going to use a condom, if you're going to rely solely on PrEP, that you really are putting yourself at risk for other infections. Concerns are raised again about adherence. Again, females related this to, or equated this to the use of oral contraceptive pills. So, you know, you might take the pill, skip a few doses. You might have some side effects, stop taking the pill for a couple weeks and then restart it. We also discussed with them possible issues related to the stigma of taking PrEP. And so, again, people said, yeah, you know, some people might think you've got it being HIV because you're taking the pill. And then someone else said, well, you can't worry about what everybody else is saying or what's going on. You've got to take care of yourself. And that's how he or she feels. And then lastly, we talked about the availability and access to medications as a potential barrier. And so, again, the participant said, you know, it shouldn't be like for only rich people before, because then the poor people won't be able to get it. And this is an issue that has been raised quite a bit in the national dialogue about PrEP implementation, is the people who are most at risk for HIV are probably also the people who are most marginalized, probably the people who are most impoverished, probably the people who have the least amount of access to health care. And so how do you get those people into a clinic and get them engaged and give them the options of using PrEP or another HIV prevention method? And then the last point was, I think if you get it by your doctor, your insurance should be able to cover it. Because if you're getting it like outside of the doctor, and then I think it should be basically affordable. So this person was just saying, we have to make sure that we can access it. They were thinking maybe outside of the clinical setting, but I'm not sure that that's actually going to be feasible. So in summary, providers, you know, there was definitely a sense of awareness of PrEP, but still that there had been little to no demand to date. There were concerns about resistance and the cost, which I think came across not only in the focus groups, but also in the surveys. And again, this uncertainty about who are the best candidates to give PrEP to. Potential users, I would say overall there was probably relatively low levels of knowledge about PrEP, but definitely a willingness and interest to learn more about it. And again, I think the concerns about promiscuity, condom use, and adherence were pervasive not only throughout the survey, but throughout the different focus groups and among the different high-risk populations. And so I think this is a good point for us to open the discussion, but my thoughts about how we move forward with PrEP, I kind of broke it into the community level, the provider level, and the system level. So again, there are these multiple studies that are starting or about to start in DC. So I think we need to get ready. But clearly education and awareness, not only of patients but providers, is necessary. And then at the provider level, I'm not really sure if there's interest. You know, again, we spoke with infectious disease providers, but I think that there's a whole other cadre of healthcare providers that we need to tap into and educate about PrEP. And then my own personal interest in this is how to determine the best candidates for PrEP use. So some of the work that we did was really trying to form the development of an assessment tool. So we know there are screeners out there for heart disease and for other chronic conditions. There are actually screeners out there to look at people's HIV risk. There's a new screener out there that was developed by CDC to look at a person's HIV risk to see if they would be a candidate for PrEP. And so what we're trying to build locally is a tool that would not only incorporate that HIV risk, but also incorporate their healthcare seeking behaviors and their adherence and willingness, because those are going to be key factors in determining, just because you're at high risk for HIV doesn't mean you'd be a good candidate for PrEP. And I think at the system level, again, we need to work with the insurance companies and figure out the reimbursement issues. And also, if there is increasing demand, how are we going to accommodate this? And with that, I think I will stop.
Let me say one thing about the reimbursement.